Good morning, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. I'm joined this morning by Mr. Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. He's going to start off today by giving us an update on our current numbers in the community.
Well, good morning. So we have 18 positive cases in Knox County. We have continued to see slow growth of cases across our region, which is good, and that means that a number of you are doing the things that are being asked as the front line of the community with social distancing, shelter in place. And while we hear that positive news, that's reinforcement to continue doing those activities right now. As you probably saw, the governor, we have continued to extend the shelter in place, and that's being evaluated on a daily basis. Social distancing is going to be in place for a much longer period of time, and so please stay very diligent about that activity. From a testing standpoint, we tested a number of patients throughout the last week and continue to add to our numbers. We've tested over 220 patients, and happy to say that over 80% of our tests have yielded a negative result. So that tells us that we're not seeing a widespread transmission of COVID, again, due to a lot of the activities that everybody's being diligent about. But again, reinforce that now is the time to really stay on top of that. Weather's getting nicer, it becomes easier to be outside and to look to go back to being in gatherings, and that's certainly not something that we can do. As we look at our data, continue to forecast that our potential peak is in early to mid-May. So we really want to break that curve, keep that curve as flat as possible, allow our healthcare team to be able to take care of those individuals that do come to the hospital needing care for COVID and other illnesses as well. And right now we're able to meet that demand for not only Knox County but for the region. A number of our hospitalized COVID patients have been from outside of Knox County, but we as a regional center serve that need, and so it takes everybody helping us to flatten that curve, utilize our triage line and our outpatient services where appropriate, and we'll continue to test where appropriate and really have good data to make informed decisions.
One of the things that Adam mentioned was the fact that we've seen a relatively slow influx of patients from our community. We have seen some sicker patients that have shown up over the course of the past week or so that have been in our hospital and in our ICU. So it's important to realize that while social distancing is helping with all that, and we want you to continue with all that, that we continue to see some very sick patients that come to the hospital and utilize our ICU services. The measures that you all have taken and that we have been preparing for the past several weeks or so, though, have been very crucial in keeping us ahead of the curve as far as our facility and our supplies, as well as our resources with the ICU. So we thank you all for taking care of that while we continue to prepare. One of the other things that we get asked about frequently is what all benefits have we had by being in our rural community, and also what has happened over the course of the past few weeks as far as the science behind what's going on. I would say one of the biggest things that's happened, certainly, and Adam being a pharmacist can comment a little bit more on this as well, is that we've seen a lot more research and a lot more experience come forward in terms of what medications are used, in terms of what settings we use those medications in, and then thankfully a fairly good supply of those medications. We have used very few medications in the outpatient world. We've been using some of those in the inpatient setting. But if you want to talk a little bit about what has changed in the past few weeks, it's been pretty exciting.
Yeah, and not just medication, but supplies as a whole, because we have seen that slow growth of transmission. We've been able to respond not only in taking care of patients, but also in bolstering our supplies of masks and gowns and medications. So hydroxychloroquine is the top medication that you hear about as far as being studied for treatment and potentially even prophylaxis, which there are studies still pending those results, but we have been able to stock up a very large surplus of those medications to be able to handle if we did see a surge of COVID patients needing treatment, that we feel like we could meet that need. There's also been some newer studies coming out around plasma. You've probably heard convalescence plasma as a treatment opportunity. We are registered with Mayo Laboratories, which is our reference lab that we partner with throughout the years, and it's been a very good partner, and we're now registered with them that if we identify patients that are recovered and through antibody testing and some of those avenues that we'll talk about in a little bit, that we can do a plasma donation, partner with Red Cross in doing that, and be able to use that as a treatment modality for very severely ill patients. It's only that's restricted really for severely ill COVID patients. But the hydroxychloroquine, azithromycin combination is one that we're able to have in stock and would be able to meet the needs of hospitalized patients. So again, that treatment is utilized for hospitalized patients. There are no approved outpatient medication regimens right now. As we know, 80+% of patients can go home, recover, Netflix and fluids, and get to feeling better, and that's all you need.
We'd also like to thank everybody in the community and some of the organizations that have donated protective equipment to us. That has been tremendously helpful and taken us from a critical state on many of our supplies to being much more comfortable in handling the influx patients that we have. On that note, we've been asked over the internet about the score that we received from Facebook. I was combing through some of the comments, and people had asked as to why we had received like an F+ on the social distancing score from one of the organizations on the internet. I'd like to comment on that briefly. So there's an interesting organization that put together research looking at cell phone data and cell phone tracks, and where cell phones went and how much time they spent there. And the initial goal of that was to hopefully help some of the epidemiologists figure out in what places social distancing was working and what places it wasn't working so well. And the initial mechanism and the math behind that was pretty much tuned to the larger metropolitan areas, who, if you look online, scored very well because they had intense close populations, and in the rural setting, our baseline for that was not as close. And they looked at how long a cell phone spent within a 50-meter radius. Well, of course, in our community here in the hospital, we all come from our homes, and we coalesce here at this one central location. And so that, combined with some of the other mechanisms and math and data behind that, gave us a falsely low score. I think you had mentioned earlier that our scores come up. We're like a C- student now,
right?
So we're looking better. But just keep in mind, a lot of times the science behind those types of things is very much tuned for the population centers and not so much for our rural settings. So we applaud everybody for doing a great job of social distancing. We see that in our community. We'd also like to thank all of our local grocery stores and vendors and restaurants and places who have put mechanisms in place to continue to serve our community but maintain that social distancing.
Yeah, and I would add, you know, that pharmacist piece in me kind of required to be a data geek, and so the data that we look at is more about the spread of transmission, the number of cases that are positive in our community, and something called the doubling factor. So how many days does it take for the number of cases present in a community to double? And the magic number is you want that number above 10. And the reason for that is if you're above 10, patients that are positive are actually recovering somewhere in the 10-day range at the same rate that new patients are contracting it. And while that's really important to our healthcare system, is because that means our capacity doesn't get overwhelmed. When you have doubling rates like some of the large metropolitan areas did in the 3-day range, more patients are getting sick, needing hospitalization, needing care than are recovering. Thus the overwhelming. So when we look at that data, we look good. So data, it can be manipulated in many different ways, and everybody's trying to display different forms of data to show how we're doing. A pure travel based off cell phone towers has some holes in it when we're not seeing the science behind the transmission. So all in all, while we may have an F+, which I didn't know that you could add a plus to an F, it's still failing, but our actual science-based data is much better and much more positive.
And we've seen from our county health officer, Dr. Stewart, has been very strict on keeping the positive patients that we have at home past what the normal CDC guidelines have been, so we feel comfortable that as those patients are now rolling through and being released out of their quarantine, that we feel good about that. And again, the number of new patients that are coming in the county is very slow growing. We looked in early last week at 15. grew to 17 and then 18 over the weekend, so it's been extremely slow growth.
Right.
We want to talk a little bit about, as we move forward over the next several weeks, we've had everybody sort of locked down and away from doctors' offices, and we want to make sure that everybody understands that services that they need are still available, and those patients that need to be seen, we want you to make sure that you're coming to the office and calling us and getting in touch with us for any of your medical needs. Over the course of the next few weeks or so, we're going to be opening up those services, and Adam will talk a little bit about how that's going to roll from our ambulatory setting, where we're doing more virtual visits, taking care of our more critically ill patients with more medical problems, and opening up some of our services, and that's going to be occurring over the next few weeks or so.
Yeah, and virtual visits is something that's here to stay. So as we look at reopening of services, utilizing some of those technologies that we ramped up in a very quick fashion with virtual care, will be here to stay long term. But really good point made by Dr. Stine, and one of the comments that has resonated with me for a number of weeks is the cure not being worse than the disease. And what, from a healthcare standpoint, that means to us is we do not want to see a number of uncontrolled diabetics, uncontrolled heart failure, ailments that have been left unchecked and without medical advice. It could be a meniscal tear in the knee that if it were repaired, then back to work and let go, it may require a more invasive surgery and more long-term therapy. And so where there is significant pain or deterioration from a patient, seek the medical services. We've been very diligent since mid-March about looking at our populations and splitting respiratory and non-respiratory. So as COO, I can tell you I'm very comfortable in saying that utilizing our emergency department, utilizing our medical centers and our practices, utilizing the hospital services where you have an appointment is very safe. We have screening measures in place. We have social distancing in place. Our healthcare team is highly attuned to the potential infection risk and disinfecting and cleaning, more so than I would say probably anyone in the community or across the state. Healthcare is going to be more attuned to those types of things. So don't let your non-respiratory, non-COVID related medical issues, become something that is on a larger scale, and certainly don't want to let those linger. So utilize, if you have an emergency, the emergency department should be utilized. Last thing we want to see is that there's an untoward outcome due to a fear that we've done everything in our power to eliminate the risk of transmission.
And Adam mentioned the virtual visits. I can tell you that a few months ago I wasn't a huge fan of the virtual visit. I think most of us weren't. We like to see our patients. We like to be comfortable with physically examining them to help determine what our diagnosis is. But I can tell you over the course of the past several weeks, many of us have come to really appreciate the value of the virtual visit. And it's a great way to enter into the health system right now, especially when we're really spreading our resources and trying to keep people at bay. And as we start to open things up again, as Adam mentioned, some of the important things are to keep in mind. If you have procedures that you had scheduled, if you had things that were coming up, if you have more urgent needs that have come up in the meantime, we want you to be communicating with your offices, with your physicians and with their nurses to help kind of line up as we start to roll that out, because I think just like everyone else in the community, we're getting very antsy to determine when the sheet's going to be pulled back and when we'll return to normal. It's important to realize that that's not just going to happen in one day. This is going to be a very stepwise process of rolling that out. As you probably heard from the governor and on the federal level, there's processes being put in place to look at and evaluate what patients need to be seen first. And as Adam mentioned, if people have surgical needs that have been put at bay for the course of the past 4 to 6 to 8 weeks or so, we want to make sure that we attend to those quickly. We want to make sure any patients who have become ill from other problems, such as respiratory illnesses, cardiovascular problems, or other medical problems are out of control, we want to get those patients in to be seen next also. So it's not going to be instantaneous, but we hope over the course of the next couple of weeks we start opening that back up, again with precautions in place to keep us all healthy and safe, but making sure that we're getting those patients the needs met that they have. One of the other things that came out over the course of the past several days is we're just going to be swimming in supplies, swimming in swabs. We're going to have so many swabs we don't know what to do with. I think it's important to realize, as we spoke about, it's probably been 4 or 5 weeks ago now, The test does not necessarily change what our treatment is going to be.
Right.
And as Adam alluded to, the majority of patients that we've had in our county have had the illness, have been sent home for home care, monitoring by our health department, and have been released back after a course of a couple weeks of isolation at home, requiring no medical treatment at all. So it's important to realize that that test doesn't necessarily change that. But what the testing is going to do, it's going to help us better survey what impact and what incidence we have of the disease in our community. We've had a lot of people call and ask questions about the different types of tests, the rapid tests that can be done in-house, the test that's a send-off, which we're seeing generally about 2 to 3 day turnaround time, and then of course the antibody test, which we hear quite a bit about. We initially had heard weeks ago that we would have had that by now,
Right.
But the antibody testing is coming around. But how we're going to use that is not necessarily what some people might think, that we're just going to roll that out and test everybody in the community.
Right. And so a key element with testing is, from a Good Samaritan perspective, we are committed to utilizing testing that goes through the FDA process. So they have an emergency use authorization that is ramping up testing on all of those fronts that Dr. Stine mentioned very quickly. But I have heard of other systems across the country that have acquired testing from outside of the country and have rolled it into their system to try to rapidly respond. But unfortunately, the accuracy and the potential value of that is outweighed by those issues around accuracy, and we're trying to make informed decisions with a tool that we can trust. So on the testing front, as President Trump mentioned that we would be swimming in swabs. I can tell you right now we're not swimming in swabs, but we have been able to ramp up our supplies and feel good about that. So what that means is that we're able to relax some of our testing of symptomatic patients with the molecular test like you get at the respiratory clinic. Antibody testing, on the other hand, is about testing for the illness was present, somebody has recovered, and now they've developed antibodies. So somewhere in the 10 to 12 day range after somebody was sick with COVID and has recovered, your body's developing antibodies. A couple of things. If you're immunosuppressed, and we've had a lot of questions in the past about immunosuppressed individuals, you may not develop those antibodies, so the test may not be all that valuable as far as identifying that population. What it does help with, though, is identifying how many individuals in our community have had COVID-19, have went home, recovered, self-isolated, and now have some immunity. It remains to be seen if that immunity is 100% and you cannot contract COVID-19 again, or if you could contract it again, but the chances of your illness being significantly less are there because you have some natural defense. The antibody test also that we're looking at and partnering through our Mayo clinic will be available in the next few weeks, and we're discussing how that will be rolled out. That's in partnership with Knox County Health, as that doesn't help or that doesn't assist Good Samaritan in how we treat patients. That helps us to identify presence of the illness in the community, and also helps to make decisions as far as reopening, because then we have an idea of how many community members have contracted COVID-19, have recovered, have some antibodies to that help them to be better prepared if they were to encounter the illness again. This is a blood test, so right now, if we were to roll that out through Mayo, it actually would be coming to our lab, a blood draw that then is sent to Mayo. There's a lot of effort going on in making that a point of care test, where it's a finger stick of blood and then a pretty rapid result. That's where some of the accuracy issues have lied, so we're not at a point to roll that out, because again, at the top of our list is the quality of the decision making that can be made from the test, not the quantity of the test that we can do, and that we fear that we may have some false negatives or false positives either way. The last piece I would mention on the antibody testing as we roll that out is specificity. So COVID-19 is a coronavirus. There's multiple coronaviruses, such as common cold there are coronaviruses that are tied to common colds. And right now, many of the antibody tests pick that up as well through the antibodies that are developed. We certainly don't want to give individuals a false sense of security with immunity to COVID-19 whenever the antibodies are related to another form of coronavirus. And for our at-risk population that we've talked about, older than 60, any disease states that may suppress your immune system, still maintain, even if you have an antibody test and show positive, still being very diligent about all of the safety measures that we've talked about, because your response may be very different than an otherwise healthier individual.
It's always important to take into account, one question we ask ourselves before we do any testing is, how will that test impact what we do? And the antibody test at this point won't change anything. So many people are asking about it. It sounds like new and exciting technology, but really it won't change much about what we're doing right now. Now, what the future holds as far as the plasma for sick patients, that has a great potential benefit. But as far as what we do with the test over the course of the next several months or year or so, probably has more to do with how much of the population had the illness. If a vaccine becomes available, do we utilize that vaccine? And what we believe so far, based on our testing and our statistics compared with nationwide statistics, is we think that the occurrence of the illness in our community is relatively very low. And so if we go and start testing large masses of populations, what we're going to find is that those tests are negative. And it doesn't really help us very much. So from an epidemiological standpoint, we will find over the course of the next few months or so, as those tests come out, we'll have a better picture of what the impact has been in the community. But at this point, it really doesn't change much about what we do. So when we are swimming in swabs, we'll have a little bit better cross-section of how many patients have it. But as far as the antibody testing, that's not going to change a lot about what we're doing right now.
And I would add with antibody testing specifically, get the question of, well, who would be eligible for that? So certainly working with Dr. Stewart, the first group would be known positive COVID cases that have been followed by the health department, and those individuals that were quarantined due to being in close contact with them. So that is something that we would certainly focus first and get a good idea of the testing related to that.
Okay. Tiffany, do you have any questions from the community you'd like?
Also, the antibody testing, there's a cost question. So as we're developing this, I can't tell you exactly what the number will be, but here is what I do know today is that the antibody testing is not a government provided testing such as some of the free testing for symptomatic COVID testing. It would go through our commercial lab, which is Mayo, and there would be a cost associated with that. I fear giving a number because that may change as we're developing this, but I would confidently say that it's somewhere in the $100 to $150 range that it would be for a test. Now again, if point of care comes out, if at-home testing comes out, that number is going to drastically go down. Right now there's very limited testing. It's ran by a lab. It's sent to another lab of professionals. So all of those costs make it a little bit higher than, in a year if we have antibody COVID testing, it's probably going to be at home, $19.99, go get it and prick your finger and send it off, and it'll be a done deal. But that doesn't exist today.
Yeah, that's after the mass production of all the testing has occurred. One of the other questions that frequently come up that we struggle with every day is, when can I go back to church, and when will we have sporting events again, and when can I go back to my favorite restaurants? And it's not that anybody is withholding that information. The fact of the matter is that we look at those numbers and those statistics. Our health department works on that. Our state government, our federal government looks at that. That time is coming, but when that time does come, we know that that's going to be a rollout of gradual nature, meaning we're all not going to just flood back into our favorite bars and churches and sporting events. It's going to be something where we look at the most essential services first, and then kind of go from there. So we're focusing obviously on when we start opening up our outpatient services and our surgical services. We know that our community members who own restaurants and facilities that need to get back to business are very curious as to what that date and what that number is. And we will keep everybody updated as best we can on a weekly basis as to what we think that time frame is going to be, but we're looking still a few weeks into the future now.
Right. And that phased reopening is what you hear across the board. There's a number of states that have started to roll out a phased reopening. Some of that has been met with a lot of criticism, as if they have the data to make those decisions, and time will tell. What I would say to the business owners is, while we're making our decisions based off of Good Samaritan and the healthcare services we provide, is have a plan. I sit on a couple of community boards with employers, and we've already started talking about have a plan. The date that plan gets enacted may change. It may be May 1st, May 8th, May 31st. That's to be determined really at a state level and with the governor's direction. but I can assure you that having a plan of how you will maintain social distancing, your disinfecting procedures will get you open sooner than not having a plan and just expecting to go back to normal business operations. Because the fact of the matter remains that social distancing, as we reopen, is going to be a part of everybody's expectation. That's not changing, and there's some projections that are saying social distancing through 2022. So as we look at that, expect that to be part of your business plan.
Yes, absolutely. The better prepared you are, that date can be very flexible, and that's what we're working with on a daily basis as to when we're going to be reopening our services. But if you have your plan in place and how that's going to function, and then also, of course, making sure that your workforce is ready for that, those are all the things that can be done right now. Just as we have been working over the course of the past 4 to 6 weeks for our preparedness, we've started the same process with us in the reopening. So we'll keep you updated on that as time passes.
And the reopening plan should also include a what if there's a positive case in your business. And we have the same thing with our reopening. What if we saw a surge? So reopening, reclosing. It may be as we address surges, we have to move in different directions. And I would suggest every business be thinking about the what ifs and have a plan to act on. I know in my conversations with Dr. Stewart, the businesses that have those types of plans, he's going to feel more comfortable about being able to move in that direction. And everybody wants to see the community get back to work, but we also want to protect the health of our patrons that come into our businesses.
What do you have for us, Tiffany?
Questions?
Okay, and I think we've discussed this before, but somebody was asking about if we're seeing positive patients hospitalized. So do you want to talk about that a little bit?
Yeah, we've seen a number of positive COVID-19 patients that have required hospitalization. And sometimes it can seem like it's a little mixed messaging when we say we have 18 positive cases in the community and they're at home recovering. Keep in mind that Good Samaritan is a regional center, and we've seen a number of patients that have come from our adjoining counties and needed hospitalization as we partner with those other hospitals, and when they need to expand their care to ICU level care or additional specialty physicians that we may have, we serve to meet that need. So at any given time, we have had anywhere from 2 positive patients in the hospital to, if you count patients that are under investigation, to 8 or 9. And we're staffed appropriately for that. Our teams are taking care of them and continue to manage that. So we are seeing patients that are sick to that degree. We've been fortunate that we have not seen an overwhelming number of those individuals.
Okay, and just to follow up to something you've talked about already, someone asked, will at-risk patients be the first in line for antibody plasma transfusion? Do you want to remind what that...
Really, the antibody plasma treatments are for those who are the most ill hospitalized patients, because what we're doing is we are taking somebody else's immunity to the illness and then transferring that to you. And it's a very temporary thing, but if you are at the peak of your illness and your body's really struggling to take care of that disease process, we're using somebody else's immunity to help you with that. So really, we see that as a potential for the future. That's not something that's commonly being done right now. As antibody testing becomes more common, then we'll have a population that we can use for that. But right now, thus far, the patients that we've been treating in the hospital that our pulmonologists have been taking care of have been pretty much the standard treatment that we have seen from our medical facilities and the tertiary care facilities in the larger communities. And as we talked about a few weeks ago, that's one of the great benefits to being where we are, is we have been able to learn from them. And our physicians are in communication with the people who have already dealt with this for the past 3 to 4 weeks or so. So they're using the therapies that they experimented on over the course of the past month or so, and we're reaping the benefits of that now.
All right.
And then there are a couple of mask questions. One of them is regarding her 15-year-old that doesn't want to wear a mask. And then the other one is just, how long do you think wearing a mask will be commonplace, and when should we wear those, and when should we not?
Sure. So again, as we talked about last week and the week before, there's 2 different uses for masks. Obviously, when we are in the medical setting here, we're using N95 masks to protect our population and from patients from being infected. That basically filters out the virus and keeps you from inhaling that virus. The statement that changed over the course of the past few weeks or so was the optional use of masks in the community. And Adam has talked a little bit about what hotspots are, and that was primarily where that statement originated from, is if you live in a hotspot where there are lots and lots and lots of patients and you have a challenging time with social distancing, that's when using a regular mask that you would make at home, a cloth mask, a scarf, something like that would come into play. Because quite honestly, those masks are not of the quality that we use in medicine. They don't filter out particles as much. But if you are sneezing and coughing and breathing, that greatly reduces the distribution of the virus in the community.
Right.
So as far as having your 15-year-old wear a mask or not wear a mask, if they're social distancing anyway, then the mask is really not all that important. If they are using good hand hygiene and not touching their face and spreading viral particles around, then that mask is not all that valuable either. So I don't think twisting your 15-year-old's arm behind their back to make them wear a homemade mask is of much value, quite honestly.
Okay, what happens if it hits Knox County hard in coming weeks and you guys end up almost full from other hospitals?
Sure. Well, I will tell you, from mid-March to where we sit today, I feel very confident in the plans that we've put in place. When we started this, it was very new, so the virus was novel, but so was the response, and feel like we could meet that surge. So when we plan for what's called a surge, our surge capacity allows us to take into account our region, not just Knox County. So to answer the question very directly, as a regional center, we also work with regional centers in Evansville and in Terre Haute, and if our capacity were to be exhausted, then the transferring of patients would be necessary. There are coordinated, what's called IHA, Indiana Hospital Association, District 10, which is our region, Southwest Indiana, calls that look at bed capacity across the entire region. So while we would be that referral center for some smaller hospitals, there are other hospitals that we work with to be able to take patients. So we feel like we have a good plan, and the key element of that is the most recent data from the second week of April, and it's stayed tried and true with the transmission of the illness, is across the state we have enough ICU beds and we have enough ventilators to take care of our region. So does it mean somebody wouldn't have to be transferred? No, it may mean that. But we do have the capacity from a state standpoint and from a regional standpoint to take care of patients, even in the event of a surge.
And that has changed dramatically. As Adam alluded to, when we started this process in March, it was showing that we were over capacity on nearly everything. And so we thank everybody for what they've done with social distancing, because that has given us the time to learn how to better care for these patients and also make us more capable with our supplies and resources to care for that surge when it comes.
And then another question is, can the virus affect you through your eyes, or is it just through your nose and contact?
Sure. So one of the things that a lot of people don't realize is that you can't really contract this virus through your skin necessarily. It has to get in through what we call respiratory mucosa, and that's generally around your nose and your mouth and your eyes. So absolutely one of the most common places that people contract influenza or contract the common cold or other illnesses like that is by contacting surfaces with your hands and then touching your eyes or touching your nose or touching your mouth. Even though we appreciate the picture on the internet of the viral cloud that's being sprayed out by somebody, that viral cloud is not necessarily the thing that gets us. It's what those particles land on and then how we touch them and then touch our own faces. So absolutely it can be spread in through the mucosa of your eye, your eyelids, your nose, and your mouth. That's why neither Adam or I have touched our faces or our nose or mouth any time during any of these presentations.
And that is a learned trait. You probably didn't realize how much an individual touches their face until COVID-19, and it's been a good hygiene practice forever, but now we have an increased sensitivity to that, and so I've sat on my hands a lot to make sure I don't touch my face.
So after all of this, do you think flu cases are going to go down like next year because everybody knows proper hygiene?
There's a lot of healthcare benefits that have came out of this from an education standpoint, from new technologies, and certainly speaking to our infection preventionists the other day, the awareness of hygiene related to infection prevention is significantly heightened, and the benefit is it applies to all viruses.
Absolutely.
And so Definitely, I think there is going to be some benefit in that regard as people are more aware, so long as this isn't something that we lose sight of.
Absolutely. You know, as we've talked about for weeks, the important thing to realize is we are around these viruses and these bacterial infections every day of our lives, and they're more intense in the winter months, primarily because we all go inside and we shut the doors, and that's where hand hygiene kind of falls apart.
Mm-hmm.
But it's important to realize that our bodies fight off these viruses and bacterial infections every day of our lives, and we encounter these things every day. And it's only a very small percentage of people who actually become ill from that. But it will be interesting to see, as Adam has said, there have been several things that really have come out of this that have been beneficial in terms of the technology that we use with virtual visits, the way that we are learning to do crisis management and utilization of resources, and what we've always referred to as universal precautions are truly universal precautions. We need to be doing that every day.
Okay, that's all.
Fantastic.
All right.
Well,
Thank
hey,
you.
Thank you, everybody, very much. We appreciate everyone's efforts and patience in dealing with this. We'll keep you updated on a weekly basis. And thank you all for taking care of us, and we'll take care of you.